Good afternoon. Let's reconvene here again. I'm Dan Catenacci. Welcome to the first Chicago Symposium for Debbie's Dream Foundation. We wanted to again thank the sponsors, the title sponsors, Boston Biomedical and Lilly Oncology, and the supporting sponsor, Norman Dinkel. We're going to move on to the next session here with a topic, survivorship and goals of care, with Megan Oden, who is an advanced practice nurse at Northwestern, and we're looking forward to her presentation.
So I want to start by saying that I don't have the privilege of seeing many gastric cancer survivors in my patient population. So meeting you all and hearing your stories has been invaluable and a good reminder of why survivorship care is so important. So a couple of things I'll be talking about. I want to focus on exactly what survivorship is and what it means to be a survivor. We'll go into some of the late and long-term effects that affect gastric cancer survivors and survivors of all cancers. And then I'll talk about what's happening in survivorship and what we're doing to improve care. This is not meant to be new information to anybody. 1 in 2 men and 1 in 3 women will be diagnosed with cancer at some point in their life, so it is a huge public health concern. And specifically with gastric cancer, 1 in 111 people in the US will get gastric cancer at some point in their life. So the incidence of gastric cancer, as we learned, is going down. So the percentage of cases that are being diagnosed new are going down. But the absolute number of new cases is actually increasing because the population is aging. And as we also learned, gastric cancer does tend to be a disease of older patients. So with the aging population, with the improvements in earlier detection of cancers and improved cure rates, and also improved treatments of cardiovascular disease, so people are living longer, the projected number of survivors is expected to skyrocket. So in 2012, it's estimated that there were 14 million cancer survivors, and this is expected to increase to 18 million cancer survivors in 2022. So what is a cancer survivor? And I know that there may be many of you here saying, well, this doesn't apply to me. I'm not a cancer survivor. But I want you to watch this video because the way that we've been defining it may have been incorrect. Do you know how I press play?
Can we press play on the
There we go.
There we go.
Doctors that I had seen, the first thing I said to them was, I don't want a hard death. And, you know, are you the kind of doctor who believes in, you know, preserving life at all costs? And if you are, we're not going to work well together. So that was the biggest issue for me. I accepted right away that it was terminal. And, you know, not in a defeatist sense, but, you know, the results were in and that was it. And so then it was like, well, how can I live with this for as long as I can? And my goal was always to buy time on this side of the bed. You know, I wasn't looking to buy time to be bedridden for 3 years, you know. So that was the first thing that I did, with regard to the doctors. Even that concerned me more even than the treatment, or, you know, because I knew the treatment was my choice and I could, you know, stop it at any time. But I just did not want a hard death, and I wanted to know that my doctor was, you know, going to take that journey with me. So that was the first issue I resolved.
So no one can say that this woman is not a survivor of cancer. She is living with it now as a chronic disease. Cancer survivorship does not necessarily mean that you've crossed some sort of finish line any longer. And the Institute of Medicine agrees that a survivor is any person who has been diagnosed with cancer from that time of diagnosis throughout the remainder of their lives. There is now they now recognize survivorship as a unique period of time on the cancer care continuum. So previously, there was a kind of a gray space between the end of treatment and the end of life. And we're now recognizing that people living during this period have very unique needs that are not being met. And so we now recognize survivorship as a unique time, and we know that patients in this phase, we need to give them some unique and tailored care. Some aspects of survivorship care: prevention, surveillance, a lot of that is guideline-based, assessment of any late and long-term effects of the cancer or of the treatment, and then intervention for any of those late effects. We have to evaluate for all of those other psychosocial concerns that come along with being a cancer survivor, interpersonal relationships, employment, insurance issues. And then what I think is the most important piece of survivorship is helping with coordination between the oncologist and the primary care physician, improving coordination and communication. So we'll start by going over some of the late and chronic effects of cancer and treatment. And just to clarify, chronic means that it's something that started during treatment and has persisted for months to years after. Late would be something that started after the treatment had ended. So some medical late effects that are particular to gastric cancer survivors who have had a gastrectomy are all of the GI disturbances that we've heard about, vitamin deficiencies, and then some others that all cancer survivors experience are sexual dysfunction, cognitive dysfunction, which we often know as chemo brain, which is just kind of a slowing down of the processing of information and responding, fatigue, the number one most common complaint, and then any particular late effects from radiation or chemotherapy. And those are going to depend on the agent used and the area of the body that was treated with radiation. So some of the GI disturbances: nausea, vomiting, diarrhea, gas, reflux, the dumping syndrome that we heard talked about earlier. Just some recommendations. Basically, talking with a dietitian about what kinds of foods are best, what schedules you should be eating on is very important. And with this chew foods well and eat slowly, I could go off on another tangent about that, but when you have to change your eating habits, it can start to change the way you interact with others in a social setting and your willingness to go out in a social setting. I heard someone say recently that when I celebrate, I eat and I drink. And I have to now reconfigure that concept in my mind. I have to find a new way to celebrate. So sexual dysfunction. There is not any specific data in stomach cancer, but I imagine it's a problem in stomach cancer patients as it is in all others. There was a 2010 survey by the Livestrong Foundation, and they found that nearly 2/3 of more than 3,100 cancer survivors had at least some impairment in their sexual function. And this is due to physical and psychological factors. Physical factors: a lot of premenopausal women, when they receive chemotherapy, can be pushed into a premature menopause. And this can cause a lot of vaginal dryness, which is very uncomfortable. Psychological factors: body image issues that a lot of cancer survivors experience. They don't have to have anything physically done to the outside of their body to have body image problems. Depression obviously affects sex drive in a big way, as does medications used to treat depression. Fatigue, like I said, this is the most common. And there was a study that set 379 cancer patients receiving chemotherapy, and the fatigue was the most common side effect they felt was impacting their life. On the right side here is a list of very common daily activities: climbing stairs, doing laundry, making dinner. And the majority of the respondents felt that all of these activities were more difficult because of the fatigue they were experiencing after cancer. Another Dutch study, I think, looked at about 350 patients, 39% had fatigue. 22% in the control group had fatigue. So fatigue is not unique to cancer survivors. It's something that a lot of people do experience. And it seemed to be more prevalent and more severe in those who were less than 5 years from the time that they were diagnosed. There are a lot of factors that can cause fatigue. So when we evaluate fatigue, we want to see if we can find anything we can reverse. So any issues with the thyroid, any problems with anemia or electrolytes, and then we have to do a very, very thorough review of medication lists because there are many medications that can cause sedation and fatigue, blood pressure medications, pain medications that many cancer survivors are taking. The only treatment that has been found to really work in improving cancer-related fatigue is exercise. And in one review of 56 trials, they found that cancer-related fatigue was reduced by exercise regardless of when it was done in relation to the treatment. So whether it was done during treatment or 6 months after or a year, it didn't matter. It always improved the fatigue. And they found that it was aerobic exercise that had the most benefit. So this is another study, and what they took colorectal cancer patients, and they assigned them to 3 different groups of activity levels. One group you will see in the red line, they did mostly sedentary activities. The blue dotted line, they were the moderate intensity activities, and they did some walking and some light biking, but then the black dotted line on the bottom, they did more vigorous exercising, like plyometrics and running. And you can see that their colon cancer-related death rate was significantly lower than in the other groups who were doing less vigorous activity. So there are a lot of psychosocial interventions that are available as well. The key point here is that you want to work with somebody who has experience in cancer-related fatigue and someone who has experience working with cancer survivors, because this fatigue tends to be unique and different from fatigue that others may experience. A lot of times it is not proportional to the amount of activity that we've done, and it is usually not relieved by rest. A lot of other things you can do. Yoga works well, acupuncture. And then these are a variety of different medications that have been tried. Some have worked with some people, but none of them have shown to cure cancer-related fatigue. Another big problem is neuropathy, and this affects many patients receiving chemotherapy. It starts in the tips of the fingers and the toes. There was a study that looked at patients receiving a 6-month course of chemotherapy, and 90% complained of some level of neuropathy, and 12% of these patients had mild neuropathy symptoms 4 years after treatment, and 1% still had severe neuropathy. So some of the psychosocial effects, and these are just as important as the physical effects, and they deserve the same amount of attention. So psychological challenge, depression, anxiety, feelings of isolation, problems with interpersonal relationships, social and financial problems. Cancer is very expensive. There are a lot of insurance concerns that people have. Spiritual concerns. A lot of people have a new relationship with what does it mean to be alive. So this, I think, is the best slide. What it does is it shows peaks of distress and vulnerability throughout the cancer care continuum. And the takeaway point here is that, as you can see in red, more than half of these big points of distress occurred during the survivorship phase after treatment has ended. And this is very normal. We get worried when it doesn't go down or when the baseline increases, when the baseline level of distress increases. That's when we worry. Huge psychological burden being a cancer survivor. Like we talked about, depression, anxiety. This idea of a new normal, I'm sure many of you are familiar with and have heard. A common sentiment that I get from patients is that everything changes, but everything stays the same. So their lives and who they are and their identities feel like they're totally brand new, yet the world around them and the people around them are all the same, and it may be difficult to reintegrate into that same old world that they had lived in before they had the cancer diagnosis. 29% of cancer survivors will experience some anxiety or depression, and actually 19% have some post-traumatic stress disorder that's related to the cancer diagnosis treatment. So, financial challenges. I'll just hit a couple of these that I feel to be most significant. The top 25% had used up all or most of their savings, and 11% found that they were unable to pay for their basic necessities like food, heat, or housing after receiving treatment for cancer. And you'll see at the bottom, 3% actually were forced to declare bankruptcy. So the treatment summary and care plan. This is a new idea in survivorship and something that many institutions are now beginning to offer to their patients. Has anyone heard of a survivorship care plan? Okay, it's better than zero. Like that. So this is an example of a survivorship care plan. This is ASCO's version. What it includes is details about the individual's care team, the medical oncologist, the surgical oncologist, the radiation oncologist, primary care physician, every bit of information about the type of cancer they had, how it was diagnosed, every single treatment they received, including doses and dates, and then a very clearly laid out follow-up plan that includes surveillance guidelines for recurrences or progression and for new primaries. So I was talking with Debbie earlier, and a lot of cancer survivors find that they neglect those screening things that they should have been doing for new primaries. So colonoscopies and those annual mammograms, those can tend to slip through the cracks. So this treatment summary and care plan can serve as a reminder to patients and also their primary care physicians that they still need to be having these tests. So this is the version that we use at Northwestern. It lives within our electronic health record. So any of your providers are able to access this. The main idea behind the survivorship care plan, in addition to giving patients all of their cancer information in one little document, is to improve the coordination of care between the oncology team and the primary care physician. So before the diagnosis of cancer, it's the primary care physician who's playing the major role in the care of the patient. Once that cancer diagnosis happens, the PCP oftentimes will not see that individual again throughout the time of their treatment and even into the years following during the surveillance period. And so what this survivorship care plan is meant to do is improve coordination along the way so that once an individual reaches 5 years or however many years, they can start to transition back to the care of their primary care physicians. And their primary care physician hopefully will feel much more confident and much more comfortable taking care of them, knowing exactly what had happened to them and exactly what their screening and follow-up guidelines should be. So I'll touch very, very briefly on advanced directives. This has nothing to do with age or illness or disease. This is just planning. You want to think about what kind of decisions you would make about end-of-life care, and you want to choose somebody to be your agent who can make decisions for you in the event that you're unable to make them. And these are entirely based off of your personal values. That is what these decisions are based off of and should not be based off of anything else. Anyone can be your healthcare power of attorney. Your physician can be your healthcare power of attorney, but they then lose their ability to treat you as a provider. So a PULST, this is just a document that we use in Illinois. This is really related to the details of end-of-life care. It's not an advanced directive. It does not explain how you would like to see end-of-life care. It's much more specific. So this is something that's used not typically as generally as an advanced directive or a healthcare POA. So I will leave you with this. Thank you.
Thank you, Megan. That was really enlightening. And there's a number of questions from the webcam, and of course, if there are any questions from the audience, I'll go through some of these here. One of them from Germany. What tips would you recommend for patients experiencing fatigue to help them be more active? And I'll expand on that. I think you did list a whole bunch. Is there an algorithm that you go through that whole list that's there of all the different strategies that you prefer? What are the things you find most effective?
So I would start by really evaluating for any sleep disturbances that somebody may be having. Those are also very common among cancer survivors. Sometimes dealing with those can really help with the fatigue. If that is not an issue, then I would start incorporating exercise, and that means different things to different people, and vigorous exercise can mean different things to different people, but you just start low and you go very slow until you build up a tolerance where you can do more. And I saw an interesting diagram recently. It was a flow: fatigue, inactivity, and deconditioning. So it's a cycle. You're tired, so you don't do anything, so you become more deconditioned, which makes you even more tired. So you have to get some exercise in there to break that cycle.
Great. And to build on that, another symptom that you mentioned, neuropathy. What strategies do you prefer to help patients with that in terms of when it's painful or numbing or whatever it is that they're feeling? What strategies do you use to help them?
A lot of patients that I see at that point, if they have neuropathy, say, I don't want any more medication. I'll live with it. If it is affecting their life, affecting their balance, which can happen a lot, then we'll refer on to physical therapy. And a lot of times physical therapy can teach them some techniques to live with this neuropathy a little bit better. There are medications. They don't all work. Sometimes they only work at very high doses, and at those doses they can be pretty sedating. So you have to really evaluate the patient and what they can tolerate and how severe their neuropathy is.
Great. And from a treating physician standpoint, we always try and stop that drug, the drugs that the culprits of doing that symptom. But even doing so, sometimes there's a lag before the patient starts to experience that neuropathy, and so we try to stop it in time. But then, despite that, we can still experience these symptoms. Unfortunately, there's a number of great questions on here. So, how about acupuncture? Is acupuncture effective for any of the symptoms that you talked about?
I do not know any of the data behind acupuncture.
There are some evolving studies looking at acupuncture and peripheral neuropathy, primarily from MD Anderson and other centers, but it's still very early in the course of treatment. Some people report benefit, others do not.
And maybe Dr. Pace will talk about that in her next talk. Here's another good one. How can a care plan be shared with multiple providers, healthcare providers, if they're at different institutions and practices?
So, different ways. Sometimes we mail them, sometimes we fax them. We're lucky that our electronic health record interfaces with the fax machines of many different physicians, so we're able to send them directly over to any physician very, very easily. And there is then an electronic copy that's given to the patient. So they're traveling and something is to happen, they have all of their information right in this document.
And somewhat along those lines, do all institutions offer this type of survivorship care in the city or in the state, in the country, or is it more unique to certain centers?
There is a big move, and there are now mandates for cancer centers to start incorporating survivorship care and survivorship care plans into their centers. It's going to happen very slowly because it's a bit of a culture shift. But yes, eventually I would expect that most cancer centers will be offering survivorship care.
Great. There's another question here. Are B12 shots common for patients in survivorship, and what might be the benefits? I think maybe getting at some of our stomach cancer patients having had gastrectomy.
So this is not something that I typically do for my patients, but again, I'm not seeing gastric cancer survivors very often. I know that vitamin B12 deficiency is a huge problem in those who've had a gastrectomy. So in that situation, yes, a B12 shot would be very important, and I would imagine that lifelong supplementation would be something that you would need.
Mm-hmm. And we do recommend that in the setting where there's a total gastrectomy to replace the B12 that you can't absorb any further. Okay, any other questions in the, yes, go ahead.
One of the questions that I have about survivorship is I really think nutrition plays a key role in it. And I'm not sure there's a really good place to go to find out that nutrition because there's so many conflicting, do you eat sugar, don't you eat sugar? Do you eat sugar, don't you eat sugar? Should you, have alcohol, or what kind of proteins and fats are good for you? So is there somewhere you suggest? Because I think that's the key to survivorship.
So what we do, we give very general guidelines, a diet that is high in fruits and vegetables, whole grains, very lean proteins. Women should have no more than one alcoholic beverage a night. There have been some studies in breast cancer that show even one alcoholic beverage regularly is associated with an increased risk of breast cancer. And then for men, it is no more than 2 alcoholic beverages every night. But
We get more.
Yeah. But I agree
I
with
like
you that nutrition is very important. But I think it's going to take some time for us to see exactly what role that plays.